is present. Thank you, John. I would also like to remind everyone that we are streaming via YouTube, so be on your best behavior. You may have reviewed the minutes of the previous meeting. I'd like to ask for a motion to approve the minutes of the April 30th, 2025 meeting of the Population and Community Health Committee as presented.
So moved.
Second.
Thank you. All in favor? Aye. That's all of us, so motion passes. Next on our agenda is informational news and items, and at this time, we will hear a comprehensive overview from the team regarding the population and community health strategy, the 4-pillar strategy, operational structure, and a review of the index of disparity. Mr. Kaufman, please proceed.
Thank you very much. Good afternoon, everybody. Thank you for having me. And just to kind of start off with a quick bit of those meeting objectives. So we did want to review that our initial strategy for population and community health. We want to define the structure for execution on the committee objectives, introduce the 4-pillar leads, as we had said, and then introduction of the index of disparity. This is kind of redundant, but I wanted to state at the end that we're going to go through that charter and ask for any modifications or anything with that. So with that, we'll go ahead and get started. And we're often asked, what is population health in our group? And that can really be a complicated answer. So we wanted to start off with that. And this slide really gives us a general outline of how we want to view or how we view population health. And it refers to the health outcomes of a group of individuals, including the distribution of outcomes within the group. So this can be used as an individual, or it can be used as individual practice or institutional and at community levels. It's an interdisciplinary approach that uses partnerships among different sectors of the community. I think one of the things with this book, because I promise I won't read all of these to you, but is the idea that this is not just healthcare. It's the wider community. It's everybody around us. So it is about public health. It's about industry, academia, all the healthcare agencies and government all contribute to population health. It brings significant health concerns into focus and addresses ways that resources can be allocated to overcome the problems and drive poor health conditions in the population. So it pays attention to social and environmental as well as medical determinants of health. And I think that's one of the features we're going to look at today is it's about those societal and those environmental factors that are really such a big portion of what we need to work on when we talk about this. And focuses on wellness instead of sick. And I think that's one of the things in the healthcare model so often we're used to is we start to focus on, we need to fix a problem. Somebody comes to us when something's broken, but really now it's about, what are we going to do for health? And with that, we need to use data. We need to do that to improve our care and use that to really help us engage with patients. So as we look at this, I wanted to go into a little bit more detail. And this is really about the strategy itself. And so when we look at this strategy, we first wanted to align with what is the system overall strategy. And this aligns with the strategy that was put in place in March. So we developed this strategy to kind of align with that. So first, we needed to unify and measure system-wide contribution. So how are we determining what work we need to do? We need to unify on a specific or focused set of priorities and get away from some of the high variability in the work that we're doing. We wanted to amplify the community health work that we've all been doing for a long time. It's part of our core, what we've always been doing. And Karen's going to focus on that in her pillar that she starts to talk through and to work through some of that. We need to hold the system accountable, and this really is about working with all of our different teams to ensure we're working collaboratively and with all areas of the system. So this includes clinical, operations, quality, all holding each other accountable to this strategy. And then finally, we need to be grounded, as I said, in that enterprise strategic plan. So all of this comes at a time when we face headwinds. And I think it's important that we kind of state what those headwinds are and just kind of work through that. So our community continues to have socioeconomic factors contributing to poor outcomes. We have significant shifts in external support. This is both philanthropic and reimbursement. This environment is continuing to change. We have less resource availability and transitioning workflows, so it's important to call that out. We need more data and insight on potential factors contributing to variability in outcomes. And we have variability in workflows and priorities that also contribute to the outcomes that we see. And I say but here because I think it's important. I think at this point this is where we have an opportunity to really start rethinking the way we do things and how we address all of this work and how we address the headwinds, ultimately achieving the goal that we're looking for, which is on the bottom there, which is to promote and ensure compassionate and holistic care for all of our patients. So with this strategy, we have this 4-pillar model. So how do we get there? We must ensure, and I am going to read this one because I think these points are critical and they really start to outline what our pillars are. And it's we must ensure the presence of a patient-centered workforce to enhance patient engagement and quality outcomes. We must develop upstream solutions for population health by identifying and executing strategies to reduce barriers to health. We must understand quality care and outcomes and ensure system priorities align and support those with rigorous process improvement. And we must engage community partners to leverage influence and resources outside of the metro health system. So I think I went one slide too far. This is the 4-pillar strategy here. And I wanted to start with, I think the foundation is where we want to start. Now, bottom, call it fuchsia colored brick at the bottom, there's really this committee. And this is the foundation we started to build the pillars off of, helping to direct the work that we do and really the foundation of how we start. We then start with pillar 1, which is that patient-centered workforce, and we'll focus on patient and population needs and how the workforce can contribute to better outcomes. Pillar 2 is barriers to health, and we'll focus on understanding factors in the community to address social drivers of health and health-related social needs. And then pillar 3, quality outcomes and performance improvement, will help us to determine where we should focus and what improvement efforts should be prioritized. And then finally, pillar 4 is community engagement, engaging with the community to understand the needs for improvement and understand the community's perspective and partnering with them to increase awareness. When we designed this, we really wanted to look across our system and see who is the right people to help us drive this. And we identified specific leaders for each one of these pillars. And so now we're going to take time to really go through each one of those and have those pillar leads kind of take us through where they're at with those programs currently and kind of their view for the future. So I'm very happy to introduce next somebody I've had the great pleasure of working with already, and Dr. Moore. You can, if you want to stay there, I can advance the slides for you, or however you're comfortable.
I'd love to stay right here. All right, yes, I'm Dr. Connie Moreland. And before I get started, I wanted to thank Dr. Shahadi and Dr. Alexander, and of course, Dr. Stepnick for allowing me to sit on this committee and to make whatever contributions I will make. And I also want to thank Matthew and Mara and LaShawn for helping me put this presentation together. Dr. Stepnick is who I directly report to. You already know Dr. Stepnick, the chief of the medical staff or the physician executive. And he instructed me to share something about myself before I get started. And I thought, a picture is worth 1,000 words. So that's myself. I'm the mother of twins. They're adults. And I feel very fortunate in that I had a very high-risk pregnancy and I received outstanding medical care. So I am forever grateful to the team of nurses and doctors who cared for me. That's really important for me to share with you because I think it really grounds, who I am as a person and what contributions I will make to this committee. Additionally, I am still a practicing OBGYN, and I do about 50% of my work here at Metro, taking care of patients, which I think is amazing. I was on call last night and I delivered 6 babies. So Metro Health, yeah, Metro Health is very busy.
That's the first time that's ever been said at this committee.
So it's important, I think, to share that because I have, my hands in patient care, and I do not want to give that part of my career up at this point. It allows me to interface with a lot of teams. I see doctors on, and nurses, anesthesiologists, NICU individuals, family practice physicians, pediatricians, the resident teams, the medical students. It's a very vibrant place to be in the birthing room. So I want to share that with you. And so I am with you. I'm committed to providing compassionate and holistic care. And then the last thing, that's my dad there. Not too many women could say that they share the same shoe size as their dad and that they're about the same height as their dad, but he was a huge part of my life. I miss him terribly. And I think, is the one who helped me to have insight into emotional intelligence. So that's about me. Next slide. So in putting together this talk, we had a lot of information that we were so eager to share, but of course we don't have that much time. So we brought it down to defining patient-centered care, discussing real briefly why it matters, what our patient demographics look like at Metro Health, and what our workforce looks like. And we wanted to highlight two approaches, basically in terms of how we create a patient-centered workforce. One approach would be to look at our current workforce and to move them towards greater alignment with the patient population. Another approach would be to identify the providers knowing the patient population and bring them in to tailor meet the needs of a given patient population. And so we call the one the audition and the other the right person, right place. Next slide. So there are many definitions of patient-centered workforce, but as an OBGYN, I favor the ACOG, the American College of OBGYN's definition, and that is the ability to provide care to patients with diverse values, beliefs, and behaviors, including tailoring delivery of care to meet patients' social, cultural, and linguistic needs. I'm a huge advocate of trying our best to address our patients' language needs. Next slide. So this is not my idea, and these days we are grounded in data, and there are many studies that have demonstrated that when we're able to align our workforce with our patient population, we will have improved outcomes. Not only that, we will likely improve the quality and reduce the cost of care. And that is very important, of course, in this value-based care background that we are currently living in. We're looking at costs. So I just want to point out the last study, looking at language concordance, the importance of course, it's intuitive, but sometimes we do need to emphasize this point that when the clinician speaks the language of the patient, we see improved communication, adherence, and outcomes are improved. It does not close the gap when we have interpreters or when we utilize interpreters. That's an important part of it, especially if they're in person. But the best match for the patient who especially is language efficiently, is not proficient in English, is to have a provider who speaks that language. Next slide. So what do we look like at Metro Health? Well, thanks to Dr. Golub, who's sitting next to me, he has captured the data, looking at hundreds of thousands of patients, and we see that we serve a very diverse patient population, which is something that we love to do. It creates job satisfaction for many of us because we're driven or drawn to diverse patients. And so what we find is that a good percentage of our patients are African American, 33%, 9% of our patients are Hispanic, and these are self-determined designations. And we find that 60% of our patients are women, and about 37% of our patients are in the age group of 45 to 64 years of age. Additionally, other than English is the most commonly spoken language here at Metro Health. Spanish is the second most commonly spoken language. And anybody have a guess for what's the third most commonly spoken language here at Metro? I would have thought that too. It's Ukrainian. Next slide. So that just basically summarizes everything to make sure that I caught the major bullet points, but as you can see, English, 92%, 3.4% Spanish speaking, and about 1.5% Ukrainian. This information doesn't really describe department by department. So we might have a good percentage of patients in a given department, let's say, for example, that speak Spanish. I do think that greater than 3.8% of the patients that we care for in the OBGYN department speak Spanish. So we need to sharpen our understanding of where our patients are by, department and specialty and maybe by condition as well. Next slide. So just to illustrate, give an example of how we try to align the workforce with our patient needs. And so, of course, I'm an OBGYN, and I think this creates a great opportunity to recognize that when women are experiencing birth or childbirth, that this creates an opportunity for our health system to audition to many individuals. So who's there during the birthing process? I don't really need to tell you, you probably have done it yourself, but of course we have the mother, right? And we have that newborn baby. We have the partner or the father. We have the grandparents. We have many relatives in and out. And we have community partners. We have our doulas who come in and support our birthing person. And so this is an opportunity for us to demonstrate compassionate and holistic care because we have so many individuals. I think more so than any other time in life is when children are born. And so we can't fumble this opportunity. We have to build trust and we have to create an opportunity to meet some of our system goals. For example, we have early entry to prenatal care as one of our system goals. So if we do a good job in this setting during our audition, we are encouraging women to come early for a subsequent pregnancy. Another system goal we have is maintaining your postpartum care. We do a good job during the birthing experience. Women are happy, they're going to come back for their postpartum care. And then additionally, infant care. We have a goal of maximizing care during the first 15 months of life. If we do a good job during the audition, then we will capture those children, not to mention the family members, because we are demonstrating compassionate, holistic care. They're observing us. Next slide. So this is an example. Thankfully, Dr. Wiper, the department chair of OBGYN, reached out to our office and said that he would like us to help him to improve the birthing experience of women. We are meeting the metrics, but we have some opportunities to do better. And so when we look at certain groups of women, particularly African-American women and women who do not speak English, we see that although we're meeting metrics, that we have opportunities to do better. And so looking at this, we try to focus on how can we help our teams to move towards alignment with our patients. So again, we noted that we are meeting the metrics, but there are opportunities and how do we move towards a better experience for our patients? Next slide.
Sure. Just for clarification, just like anything else in population health, if you're trying to move any kind of metric to a higher number, just using a intervention that is without looking at the population that mostly be affected, where you can put your resources so you can lift everybody up, then it's a lost opportunity and a loss of resources. And that's why this work is very important, is to identify, because many of those metrics, when you get to the high level, like if you're attaining 85, 90%, no matter how many resources you pull on, there are reasons why you can't get higher up because of people beliefs and other reasons why you cannot get up. But it's those where the gap is larger than the norm, where you challenge yourself, try to understand why and how can you put intervention to lift them up. That's why we look at this data. That's from a population health lens.
Thank you, Dr. Shahadi. And the analogy I use often is when you are looking at a classroom of children and you have a group of well-performing children, you know they're doing well. You want to keep them strong in terms of their performance, but you have to address the needs of those underperforming children if you want to bring the curve up. So that is why we look at those groups of women who are saying, we could improve. So what are our strategies? One, we can develop and advance a patient-centered workforce by raising awareness and consciousness about the patients that we serve, talking about the problem, for example, that we're trying to improve in a particular patient demographic. We can develop community engagement opportunities for dialogue, learning, and trust building, which is huge. And then lastly, we can focus on outcomes and performance to improve the overall quality of care. I think that the last point that I want to make in terms of doing it in a more, I guess, quick way is to use the language example as to bring home the point. So you have a provider, let's say, who doesn't speak a given language. Let's say Spanish. I speak a little Spanish, for example. And let's say I'm in a community of patients that is largely Spanish speaking, which actually happened in my career. I was placed in a location where 80% of my patients spoke Spanish. So over many years, I had to learn to speak Spanish. That was time consuming and it was probably very costly for me, right? And also there were opportunities for miscommunication, misunderstanding, but we got there. We took care of the patients. But if we sort of appreciate what our patients need from the get-go, then we identify that provider who is well matched for that patient population and they're up and running right away. And we see in those types of scenarios, the outcomes are improved, compliance is improved, it's more cost effective, and the patients have a better experience as well. So looking at value-based care, the patient's experience is key. The provider's engagement is key as well. So with that, I will stop. I was given a certain amount of time, so.
Thank you, Dr.
Any questions?
Thanks to other members doing that.
Okay, great.
Good afternoon, everybody. Yes. Happy to be with you today. My name is Karen Cook. I serve as Director of Healthy Families with Metro Health's Institute for Hope. And I've been with Metro Health for just over 11 years, and John Corlett was my first supervisor when I arrived here at Metro Health. So, and I will say it's been a wonderful journey here, and having the opportunity with Dr. Shahadi's leadership to work with a small team to develop the framework for what became the Institute for Hope has been a very special part of that journey and something that I'm here to talk with you about today. So the Institute for Hope was founded at Metro Health in 2019, and it was founded with the purpose of identifying and acting on the social factors that impact the health and well-being of the people we serve. And you can see our mission and vision there on the slide. And what I want to call out to you today is the purpose there listed at the bottom, as that statement, I think, is what really ties very closely with the purpose of this committee and thinking about how we work collaboratively across the institution and really thinking about how work to address the social factors that impact health embeds into clinical care and community engagement and all of the other things that we'll hear about today. So this slide, I might say, is a little bit of the preaching to the choir slide. So I'm going to guess you all know this, right? But about 20% of what impacts our health is what's happening here within the walls of the healthcare system in terms of access to care and the quality of that healthcare. Up to 80% of what impacts an individual's health is happening where they live, work, learn, play. So socioeconomic factors play a huge role in that. Do individuals have access to jobs that pay a living wage? Do folks have access to the educational opportunities they need? Do they have community and family support? What's the physical environment, the quality of the air and the water that we breathe and that we drink? And then certainly health behaviors like tobacco use, diet, and exercise, which I would say are also very influenced by where we live and the opportunities that we have in front of us. So what I'd like to say just a brief word about language. So we talk about social drivers of health, and it's become a little bit of shorthand. When, social drivers really are those broad community level structural factors that impact health. So things like poverty, structural racism. Health-related social needs, on the other hand, are really those individual level social needs. And that's really when we talk about SDOH screening, what we really mean is screening for health-related social needs. So sometimes we do use the words interchangeably. So I wanted to highlight for you today one of the core approaches that we are taking within the Institute for Hope and how we approach our work. So it starts with screening our patients for their health-related social needs. So we're doing this currently in a variety of ways, through MyChart, through engagement with care coordinators and social workers, community health workers. After we screen, we take the next step and try to make connections on behalf of our patients so that they can access the services and programs they need to address any identified social needs. We try to then understand whether those services were delivered, whether the patient had any benefit, and evaluate the impact of that. So really always trying to move towards underscoring that case that addressing social factors really can influence health outcomes. So this is a little bit busy, but this is a social care logic model that was published just over a year ago. It was designed at the Social Interventions Research and Evaluation Network out of the University of California in San Francisco. And what it does is really identifies the interconnected and complementary pathways that get from identifying health-related social needs to improved health outcomes and decreased avoidable healthcare utilization. So there's really 4 pathways that have been identified to connect those two things. One of them is that social service connection pathway. So we screen somebody, we identify a social need, we connect them to a community service, that service is delivered, the needs met, that has an impact on them going forward. The second one is really an emotional support pathway. So now we are engaging a community health worker to help make that warm handoff to someone in the, a service in the community, an internal service. So it's that relationship then that improves the emotional support that contributes to improved health and improved utilization. The third pathway is thinking about health services connection. So as an individual is engaging with a social worker, with a community health worker around a social need, they're also able to take the next step and connect them with primary care services, preventive care services, all of the things they need on the healthcare side. And then finally, and ultimately, is that tailored clinical pathway. So as providers increasingly have access to this type of information on social factors and challenges that patients may be facing, do they have the ability then to adjust care plans in response to that? And then in turn, that contributes to the patient's health and well-being. So we think this model really helps highlight how this work can fit into overall health system approaches. So I wanted to say a little bit about what this work means in relation to system goals. So I'm going to start with screening and then talk about response. But when we think about screening, one example of how we use this to think about connections to health system goals is that the screening results themselves can help identify what social risks might be impacting a population or a condition or a health outcome that we're working to address at a system level. And one example I'll provide for you there is that the data analytics team during this past year has done a lot of work to identify what social factors had statistically significant association with noncompliance with prenatal care and postpartum care. So what things were really contributing to folks not showing for these appointments. So having that information, being able to make that information actionable, then links to system goals for 2025 that relate to timeliness of prenatal care and postpartum care. Another example of where screening fits into this is that screening is often the point of activation for follow-up care. So outreach subsequent to screening by a community health worker or a social worker or a member of the care management team. So once that is initiated and that relationship can be developed, you can see where that ties back to those 4 pathways that I outlined on the previous slide. When we think a bit about how we leverage this work to impact system goals in terms of how we're responding to social factors, I just want to highlight 3 main ways that we respond and an example of each one of those. So within the Institute for Hope, we do design initiatives that target social risks that can impact populations or conditions, often that are the focus of system goals. So the example I have for you here today is our Food as Medicine clinic. So this clinic engages patients who are both food insecure and have a chronic condition impacted by diet. So in this case, uncontrolled hypertension and uncontrolled diabetes. And then it is a medically tailored groceries intervention that is delivered to and with the patient over the course of a year. We have seen through our evaluation that this program is really associated with improvements in A1C, inpatient stays, and lower healthcare costs. So this is the case that we are always striving to make. How does this work ultimately impact the things that we're concerned about as a healthcare system? The second way we work to respond to social factors is through a community health worker team within the Institute for Hope. So this workforce, again, as I mentioned on the prior slide, can really be that point of contact to engage with patients, to understand their social needs better, to make those connections on their behalf, and in the process really engage them with the appropriate level of care that they need. So this can tie up to any number of identified system goals, so diabetes, controlling blood pressure, cancer screenings, other preventive services that may be highlighted as part of our system goal metrics. The final thing that we do to address social factors for our patients is through partnership. So we do a lot to build partnerships with community-based organizations and not just connect folks, not just make a referral, but really build some shared work and shared programming and very intentional design around things. So one example I have for you here today, and sorry, I've been fighting a cold and it's coming apparent in my voice right now. Matt, can you pass me that water? Sorry about that. Okay. So I've highlighted a partnership with United Way and Benjamin Rose Institute to really develop and deliver on a model of medically tailored meals. And again, this is going to patients who have both social factors and particular clinical indicators that can be improved through this type of intervention. So this is one example of how we might work with community-based organizations to really leverage and address the needs of our patients. That is all that I have for you today.
So next up, we're gonna bring Nisreen.
Oh, you good.
Nisreen to kind of cover pillar 3, and this is the quality outcomes and performance improvement. Nisreen's gonna cover very briefly a little bit on index of disparity, but we want to use that as just something we're gonna be bringing back to the next meeting. We had initially planned to bring it here, but it's far too complex. We wanted to have enough time to really get through it and talk about it in some detail, so we'll just be touching on it today. Nisreen?
Thank you. Good afternoon, everyone. My name is Nisreen Kazel. I've been here before, and I've been at Metro Health. This is my 19th year, and all has been in quality and now population health. So I'll be talking about our quality system goals and transitioning from 2025 to 2026, we will still continue to align our system goals with external entities and our value-based contracts. And the reason is this alignment is important for the financial rewards that will be invested in the system, in our patients and in the community. We also will be focusing on process improvement, education and training. This year, we started a training class or program around process improvement. We called it FISH, Fundamentals in Improvement Science for Community Health. And it's based on the IHI process improvement model. And we will continue that in 2026 with new cohorts too. And lastly, we do every year definitely collaborate and align our goals with our ambulatory network. And, we're awaiting the new ambulatory structure to promote quality and process improvement. Some of you.
Yasmin, before you go for it, I just want to be very clear. The reason we're bringing in quality of the ambulatory in here, because everything we do when it comes to population health is truly about the health of the individual, of the community that we serve. So we need to have measurable outcomes of the interventions that we're doing. And we have to tie them into some system goals. So we're all aligned within our health system on where we're working on these quality metrics. And we also will align them with the resources that might be available through payers, to the government, etc., so we can draw down funds so we can invest in our population and our community. So it's a full circle.
Some of you have seen the goals, our 2025 system goals. We have 16 of them that span over the life of a patient, from also preventive measures to chronic illnesses and their outcomes, mom and baby measures. And the last column you see there is the index of disparity that we'll be talking about a little bit more on another slide and in the future, like Matt said. And these goals are usually strategically picked every year. They go through a process of approval and review by the Board of Trustees. Like we said earlier, they are definitely aligned with external agencies, Medicare, Medicaid programs, as well as our value-based contracts with the payers. They are evidence-based, and they definitely include, they go over a patient's lifespan, as well as we were able last year to start using a new metric called the index of disparity to apply to those system goals. The index of disparity is used to understand what gaps in our system goals exist among the different patient populations. And this, again, this has mentioned before too today, that this does help us zoom in on certain populations to see where's our lowest performance and act on that, because sometimes we do reach a certain plateau on measures. And this is definitely where we start looking at populations and the details of those populations. Any questions? That's it.
Great. And for our last pillar, Ramona Brazil will present the community engagement.
Thank you. My name is Ramona Brazil. I'm Executive Director of Government and Community Relations here at Metro Health, and focusing on government on the local side, certainly in the external affairs team. So I'm glad to be here with you today. I have been at Metro Health for 3 years. I feel a little bit like the baby of the group, but certainly I spent, I think I've told some folks, about 20 years at our county health department in public health. And also a registered nurse by background, started in labor and delivery. So kind of all of those things together is the perspective that I bring to community engagement. So first, I just want to acknowledge that, we view community engagement as absolutely necessary and fundamental. You know, I say that I meet two people in the community, either patients of Metro Health or potential patients of Metro Health, donors of Metro Health or potential donors of Metro Health. And the reason I say that is because people make a decision about where they go for care before they pick up a phone, before they log on to a website. It's what they've heard from their family member. It's what maybe a previous experience is. And by understanding that and being present in the community, we hear a lot of those things before it ever comes through our doors. What is community sentiment? So really, community engagement is bi-directional. And it's not just what we want to say, but what others have to say and how that comes together, and having more relationships, not just transactional interactions, but ongoing, consistent relationship building and engaging a wide spectrum of audiences in doing that. And so we certainly are from residents in community groups, grassroots, institutions, up to the CEO of an organization, but we also need to be just as cognizant of a Black club in a certain neighborhood, because, you know, often they have more of a pulse of what's really going on in that community than even sometimes the leader of an organization that might be more prominent in a community. And as is really because of my background in public health, use a public health lens of what that means, and certainly will show you that. And also to acknowledge that Metro Health is, of course, a healthcare provider and one of three of the large health systems here. But we also have institutional power as a large employer, as an institution, and we do have a lot of influence that we can use to work in partnership to improve health. So it's kind of looking at Metro Health from a variety of perspectives. So this definition of community engagement comes from the Centers for Disease Control and Prevention. So it is working collaboratively with and through groups of people to address the issues that affect those folks. And we can use community engagement to bring about behavioral and environmental changes that helps improve the community's health and its members. And we can do in partnership and coalitions, and we can mobilize resources and influence systems. And through that, we can change policies, programs, and practices. And those things can then be used to address the social drivers of health, community health, and improve health equity. So I've probably been saying this definition for 3 years. And I'll use every opportunity I can to share this definition, because sometimes community engagement is boiled down into maybe a community event where we have a table and we give away things. But this is really much bigger and much, much deeper than that thought. My little quote went away, but one of my favorite quotes that kind of brings it all together is when you talk about community engagement in that CDC definition, it's really nothing about us without us. And if you kind of put that at the base of what we're doing, then you're keeping people centered on you can't make decisions for other people and not understand their perspectives, their challenges, the barriers that they face. And the best way to know is to talk to them. And sometimes that's like a very simple thing, but to engage folks, especially as early as you can in a process. So in looking at how, to organize this, because community engagement really does occur across the entire system. It is Metro Health is known for our community work. I think, many of the conversations that I start with people might say, we want to reach out to Metro Health first because you guys are always in the community. We know that you're committed. That's usually how it starts. And then they ask people, it is they want. But certainly something the system is known for. But we can do it in a strategic way that helps us to advance our system goals and improve health. So we have to have shared meaning and understanding. What are we talking about when we talk about community engagement? Having the system priorities and guidance to help us understand where should we be focusing. As we look at, disparity indexes, and we might say, okay, well, we're doing pretty great on breast cancer screenings, but in this population, in this neighborhood, we're not doing that well. Well, we can work with our mobile mammography. We can say, we're gonna go into these neighborhoods. We can work with the community organization in those neighborhoods that's trusted, that provides us a space, that helps to recruit people to come. And that is a way that we start to align our resources, the data, the community partnerships, and we target where we're going. And just as Karen shared, our community engagement frameworks, so we don't have to reinvent the wheel. There are our community engagement. When I first started, I had about 3 weeks where I wasn't very busy. I mean, it's gone away since then, but there were 3 weeks right when I started. Part of what I did was a lot of research on different engagement frameworks and really looking at the socio-ecological framework, which just talks about social drivers of health, how people are related to their environments, to their families, to their communities, and to society at large. Then, of course, we have our own internal team, small but mighty, that to do the work. We need to reinvigorate a community engagement advisory board, which has looked a little different depending on kind of where we are. Look at internal cross-system collaboration. My job isn't just external. Metro Health is also very internal because you have to know a lot of people in departments and what are we working on and what are the priorities and what resources do we have. And then how do we match that to what the community is asking for and needs? And often we act as a bridge to that. And then those strategic community partnerships and collaborations. Who do we need to know? Who do we need to get connected to? Where do we need to be? That's an ongoing challenge and an ongoing need, and always looking for what are those opportunities that we have to expand our partnerships. And then, of course, looking at the outcomes part of this, what metrics do we want to look at? We certainly are very busy, but we're not going to improve people's lives just because we're busy. So we want to look at, well, what metrics should we actually be tracking? So this effort helps us to look at where do we want to focus. We're always going to be very busy because there's always a lot of things going on, but how are we looking at our priorities and how are we focusing on those things and putting some of our resources behind it? And then, of course, just analyzing that data and reporting it out. So we work with strategy to look at, well, how do we approach this work? And first, I'm just going to start with system connections as being kind of the undergirding of all the work. Like I said, we were very busy yesterday. We had 3 voter registration events. We had the flag raising at City Hall. And so we were all divided up and all kind of off in different areas. But it's not just for our team to be out there. It's how do we bring that back? How is it connected back to the system? So everything we do in a way needs to be connected back to the system. It's not us acting independently. So we do that through presence. We need to be consistent in our presence. So out at community events, out at meetings and coalitions and meeting with people, the physical presence of being there. And, last year we probably attended over 200 community events. And sometimes you'll see them and they're large, whether it's we're at Asian Fest or Pride in CLE, Juneteenth, the Puerto Rican Expo, which was on campus. We were just at Fresh Fest this past weekend. Those are large events, but you won't see all the pictures from when we're in the basement of a church or, we're lugging our cars full of stuff and we're headed off to something, or coffee meetings or, those types of things. But that constant presence is very important. And then listening. So what are we hearing? How is it consistent? Is it different in some neighborhoods versus others? What are people saying? What are they feeling? And then we, bring that back. What did we hear? And sometimes those are tough conversations about what we heard, right? Sometimes they're wonderful and great, and sometimes they're tough conversations, but we certainly bring those things back and we do that back and forth. And then building those relationships and looking at our resources. So we should think about the fact that we provide resources out. Sometimes people only equate that to money. Okay, that could be sponsorship, but it also could be, where is the mammogram thing going? And is it matching where we said it needs to go based on need? Or it could be our doctor who is going to go speak to a community group on a Wednesday night. That's a resource that we're providing back to the community. And a lot of community groups that we work with are very appreciative of when you take time, or when a provider takes time and they're talking to their community group directly. But as I said before, all of this really does need to connect back to the health system. So our team really operates in two kind of different ways: an operational function and a system enabling function, which I think we talked a lot about during strategic planning. So on the operational side, we manage community sponsorship funding, which means we set up a centralized application process, review it with cross-system review. We provide, that out to the community organization. We organize our presence at that event and different departments that might go. We're working on a mini grant initiative. Tony Miner is leading that. And we're looking at how do we provide funding to community groups for their ideas on how to improve health. And we can do that in alignment with our system goals and our priorities, their priorities. What are their ideas? How do we support that? Then the community events I already talked about. Advisory council, we need to bring back. We organize listening sessions and community talks, health talks, and we focus on special project initiatives. And this is really where the system goals will help to direct our work. So if we're focused on behavioral health, if it's violence, it's maternal health, how are we focusing some of our efforts specifically towards those things? But on the system side, on the enabling function side, we work with departments across the system on how do they design their programs or evaluate their programs? How do they know what people are thinking? What feedback are we getting? If they're thinking about, well, who could we partner with in this grant application? Who do we know, right? And like, what is the work that they're focused on? How do those things come together? We certainly participate in lots of partnerships and collaborations. We might be the system representative that sits on that. We also may be looking for opportunities. Where should Metro Health be? Where to have a seat at the table, and then working internally to figure out, well, who's the best representative to be there on behalf of Metro Health. And then we are a connector. So we connect community to internal stakeholders. And like I mentioned, we are always building relationships wherever they might be. They may be great and they might need work and they might be new and they might be old, but how are we constantly building those relationships? So with
Ramona,
that,
I have a question about the listening sessions and community talks. They're a very powerful tool, but they could also hurt an institute if they don't have the correct process in terms of hearing from the community, and they're taking their time and risk, of being very open, and it can't just sit there. So what is the process in terms of you hear something from the community and it makes its way into the system itself?
sure. So first, to even to acknowledge, we have to be ready when we go. So sometimes, and I feel like I might be a break at times, of are we really ready? Because sometimes people want to have a conversation and engage the community, and we're not in a place where we might be able to change or address what they're asking of us. We need to, but we also need to say, we're going to be responsive to this, and you got to be open to what you're going to hear. Sometimes we are, people may design a listening session around a particular topic. And then you go to that meeting, and that is not what people want to talk about. They want to talk about something totally different. and maybe you weren't really ready for that conversation. So number one, understanding that can happen and that you need to be responsive to what they're bringing. So being really intentional about when we do them, and that readiness, I think, is first. Second, you know, but second, you know, I feel like right now we have a lot of leadership support for this, so that is also great. That when we hear something, we can bring it back and we can get it to the folks who are in positions to be able to do something about it. Because sometimes if we don't have the right people involved, and especially early, that some of the things that we might hear or people are interested in, might not be the right people at the table who can really make that happen. So that's part of why I was saying the internal relationships are just as important as the external relationships, because I need to be able to say, this is what it is. I think the next thing is that we have to be really honest with the community about what we can do and what might be barriers. Certainly that we can't do everything we hear, but we have to be committed to transparency and honesty and coming back to them with where that landed. So it's very nuanced, I think. But I think that it's an important way of making sure we continue to keep dialogue going.
And I'm gonna try to answer this in the next slide. If we can go to the next slide. Thank you, Ramona. So we've thrown a lot at everybody today so far. So I'm gonna bring you back to those 4 pillars. These are kind of intuitive, but not as easy when you try to put them in writing. In other words, every leader in population health should be thinking that way. So if I take an example, let's go back to that prenatal visits and engaging moms into coming in, getting the care that they need so they can have a healthy baby, a healthy delivery. So if we don't start with the right workforce that can be engaging and be able to have that communication and that the patient feel at ease to engage with the provider, then we have failed that task. I mean, as simple as the patient preference between a male and a female OB doctor. I mean, as simple as that. That can be a deal breaker for some of the moms. So just to start with, the workforce that we have in place that is ready to engage in the right way with our patient. This is where we start, because we are in the healthcare delivery business. Then we have to go back and look that specific mom. Now we have the right doctor connecting to that mom. Why is this to-be mom not showing up, or what is preventing this mom from showing up to the appointment? And we're gonna bring science to this, and this is what Nazreen is talking. Some of our science and our screening have demonstrated there are specific demographic and the barrier to care that prevent this potential mom-to-be or future mom-to-be from showing up. Like, I believe one of the finding, if the household have more than 3 siblings in the household, if you have more than 3, you're less likely to show up. What does that mean? Does that mean you need more support with babysitting, somebody to look after your kids? You cannot just bring in 3 other with you to the appointment. You need to have a telehealth visit instead of an in-person visit. Mm-hmm. What are the solutions that we're gonna bring to remove that hindrance to the care? Now, we go and do this. Have we, on a population level, improved our outcome? And that's where the measurement of the quality outcome comes into play. Because we don't want to do this work and hope for the better. We want to make sure that what we're doing is demonstrable improvement in the health and the health outcome. Finally, in this specific example, and the vision is as follows. We're not going to go, I think one of the mistakes that health system might be doing in community engagement is wide open engagement and about health and wellness. We want to be laser focused around specific initiatives so that we can be responsive. We can listen and hear from the community, not only listen and hear from them, ask them for help with the intervention and the outcome, and really learn from them where they need our assistance. So it's bi-directional, it's not one way or the other. If we put all this together, I think we are into something really, really powerful in here. And that's why we brought these 4 pillars. As you can see, it's not one person's work, it's not one team's work, it is an entire collaborative work that we want to bring together going forward. So Matt, back to you.
Thank you. You hit a bunch of the pieces that I wanted to go through, and I really did want to bring all this back together. So thank you to each of those pillar leaders. And we wanted you to see the great expertise we had across the system. And really our plan and structure is to bring that expertise together so we're working synergistically and really moving on these items. And so I'm just going to advance to this last slide, and I kind of wanted to take us through a working example of how this would kind of work. And very similar to the topic that Dr. Shahade had, if we look at preterm birth, and I start with that one because that is likely to be a state metric that we are going to be working on in 2026. And it's a good one to go with because we're so focused on prenatal visits and things, and those are almost like process measures. But when you bring something like preterm birth, there's a lot to that. And that is not just a health system that's going to fix that. So we have to look across that. So when we look at our different pillars of how we kind of wanted to walk through this. And we thought, we have preterm birth, and we start with pillar 1 with Dr. Moreland. And her work might entail like identifying and implementing provider competency modules related to preterm birth. We might develop a patient-centeredness program for the OB staff. This type of intervention is really then informed by some of the other pillars. We're going to take some of that SDOH findings that we have from the Institute for Hope to help us inform that. We will be using the index of disparity to help us to understand what types of interventions would be used there. When we look at pillar 2, and we get into that work, developing screening and analysis on social contributors to preterm birth, so that we may have to hone some of our screening or be specific in areas where we screen to help identify some of those issues that the community is having. And we want to design and implement social programs tailored at some of those things that we've identified. So that work would be going there. That's again informed by some of the parameters we get from our quality metrics and from those the index of disparity. When we look at pillar 3, it's always good. I look at pillar 3 as that science piece that you had said, Dr. Shahade, and really kind of tying to, we need to understand where everybody's sitting. And this kind of sets that baseline. It's kind of setting our drive. This is where everybody says we need to be. This is what we need to get to. Where is everybody else in comparison to this? And we can start to look at that. And then finally, in pillar 4, it's really working with Ramona and understanding when we have those community outreaches, we're really tying it back to this. We're laser focused on an intervention or a problem like this, talking to the community. And to your point, Ms. Mendez, like when they come to us and say, we want this, we now have a team we can bring that information back to, and we can really start to hone in and move on that faster and really work on interventions for that and really hit it across all the different planes that we need to. So I think of this 4-pillared structure. We have it in pillars, and that's really for the leadership thing. It's probably better served as a Venn diagram when we look at it operationally. And that's really what it comes back to with that. So it's about us working synergistically, rowing in the same direction. I don't want to throw too many of those, those analogies at you, but that's what it's about when we brought this structure together. So with that, I just wanted to open it up for any discussion or any questions that you have. Okay.
You said it all. Great job. Really excited about this work. It's very data driven, but also has the same touch of real, true community engagement. And I think this is going to be system changing. So thank you all for your work, and I'm really excited to partner with you on this. So thank you. Thank you for the informative presentation, because I do read my notes. Next, we will have a review of the restated committee charter. Mr. Wellings, please proceed.
Madam Chair, I'm going to defer Mr. Kaufman on the charge.
Okay, so this is a modification of our initial charter that we had. So we put it to the group. If you'd like to take some time to review that, as it's in your packets, we're open to any feedback or suggestions that we can take back to the group to modify, and then we'd like to put that forward for approval at the governance committee.
And as you can see, it is probably the shortest, most concise on one slide charter.
This charter was really built to align with those 4 pillars in the structure that we had. So we had charter alignment, and we really have that operational alignment of this committee.
Streamlined.
We try.
Just giving folks a minute or two to review it.
Any questions, modifications, any suggestions? We can go ahead and move that forward for the approval of the governance committee.
Thank you.
Thank you so much.
With there being no further business to come before this committee, this meeting is adjourned.
2:37.
Good
job.
I think that's a record too. We waited till John said it.